have not limited myself to treatment only because I think it would be a little bit too easy to just update you about biologics. So what I'm going to do is to update you with the state of the art, with either diagnosing, treating, but also imaging and identifying patients, which I think gives you a more complete picture of the disease. So I will try to really focus on the very, very last data. The last 2 years of the literature will be shown here, and when I needed it, I also went back in time and took also literature from older days, but in fact, this is what I'm going to focus on, mainly the last 2 years. So for those of you who might not be rheumatologists, and especially, or even for those of you who are rheumatologists but might want to have it more precisely, the question that I would like to ask before we start is, which patients are we really talking about here? When I speak about axial spondyloarthritis, what exactly do I mean by that? I mentioned that before, and this is another way of showing it. We are talking about a concept, and this concept of spondyloarthritis is what you see here. We are trying to put together some symptoms, some, let's say, identified patients into one diagnosis, and we would like to start with the axial spondyloarthritis, then go over to peripheral spondyloarthritis. We all know ankylosing spondylitis, but we also have the spondyloarthritis patients who have no radiographic changes, and this is the way we are thinking nowadays in rheumatology. We are talking about earlier stages, no X-ray changes but similar symptoms, later changes, the same symptoms but with X-ray changes. This is the concept. Again, this is called axial spondyloarthritis because it has to do with the spine, and the others that are called peripheral spondyloarthritis are including psoriasis and psoriatic arthritis, and also patients with inflammatory bowel disease. This is what I was speaking about before. So for those of you who might not know exactly how we diagnose these patients, I'm showing you here our classification criteria in rheumatology. What we are doing is really to go in to a pretty young population. This means patients who are less than 45 years of age, and of course this is not a disease, you are allowed to be young, but they have to have specific symptoms. And the specific symptoms are back pain with a duration of more than 3 months. Some of these features clinically, this means peripheral arthritis, enthesitis, eye involvement, skin involvement, gut involvement, and so on. And then they have to have either imaging which is positive. Imaging means sacroiliac joint changes which are either inflamed by MRI or having structural changes on X-ray, or they have to have a genetic background that is positive for HLA-B27. This last thing I will discuss at the end, again because, or also on the background that there might be different prevalences of B27 in different parts of the world. And I will show you what is new in the genetic background of spondyloarthritis. And for the peripheral spondyloarthritis, we also have the classification criteria saying that we have to have peripheral involvement plus some other clinics. I will not concentrate so much on that here. I just wanted to mention that there are these criteria. So if we want to talk about treatment, we also want to say or to speak about how these patients will come to us for treatment. So what are the referral strategies that are relevant for GPs, for orthopedic surgeons, for other colleagues, for example, also gastroenterologists who might find a patient having spondyloarthritis? How would we really like to increase our chances to get a correct diagnosis and see the patient in rheumatology? There has been this screening approach, just as an idea, published very many years ago, about 10 years ago, where it was said that actually if you have a patient who is young, then please refer him to their specialist in rheumatology if this chronic back pain, this means with duration of more than 3 months, is also inflammatory, or if there is imaging positivity, or if there is B27 positivity. This is pretty easy, I believe, and to me it doesn't really make too much sense to say we take everything and if something is positive, send the patient to a rheumatologist. What we have now developed, and I think that makes sense clinically also, is a pretty easy way to follow patients. This means more or less a two-step referral strategy, and that's also what we apply in our area in terms of cooperation with GPs. So we would like to see in rheumatology patients who are young, who have chronic back pain, this means a duration of more than 3 months, and where the GP or any other specialist has asked 3 simple questions to the patient. Does the patient have buttock pain? So not any kind of back pain, really very deeply obvious back pain. So buttock area is important. Do these symptoms improve by movement and they worsen with rest? And does the patient have psoriasis? You see, I'm not talking about B27 here, I'm not talking about inflammatory bowel disease, I'm not talking about imaging. All these questions were asked, but the 3 main ones were these ones. So this is the statistical model that showed these 3 questions as being important. And if the patient has 2 out of these 3 positive, it's very simple, everybody can do that without doing any lab tests and so on. So young patients, chronic back pain, 2 of these 3 questions being positive, then please refer to the rheumatologist. If a patient has less than 1 being positive, then at least, and this is of course being applied in Germany. I know again there might be differences where else, but this is the way we do it. Then examine the genetic background, and again I will speak about genetic background and other ways of examining the genetic background later. But at least here, examine B27. If it's positive, refer to the rheumatologist. Why do we think that this is important? Or is it something we just made up? Or is it backed up by numbers? We believe that this is important because we have seen that we have a very high chance to get the correct patients. The sensitivity is very high and the specificity is very high. The specificity means of 80% that 8 out of the 10 patients who will come to the rheumatologist will also be diagnosed correctly for spondyloarthritis. The specificity means that those patients that we will not see, 75, let's say we didn't see 100 patients because they did not fulfill this criteria, 75 of them were not seen because they didn't have anything, and we missed 25% of them who might have spondyloarthritis but are not yet apparent. So obviously the results confirm this whole suggestion for a simple referral strategy. Now, 1 or 2 words about inflammatory back pain, because this is something we really consider as important in diagnosing spondyloarthritis. You do know that, or you might have heard that there are different criteria or how to define inflammatory back pain. You might either rely to the first, to the second, or to the third criteria set. I believe that it doesn't matter which set you're using. In fact, there is 5 main symptoms that we are considering important, and me in the clinics, I never go to the criteria sets, I just ask questions to the patients. For example, does the pain start at an early age? Does it have a long duration? Is there a morning stiffness in the lower back of more than 30 minutes of duration? Do the symptoms improve with exercise and worsen with rest? Is there an awakening at the second half of the night? And is there also an alternating buttock pain? This means not only on the left or not only on the right side. These 5 or 6 questions, if you ask them, the more you get as being positive, the more probabilities that we have inflammatory back pain. Now, as a general way of showing things, and I think that's important for the GPs especially, is the question, or how frequent is inflammatory back pain in the general population? This means, am I now, if I show you these definitions, am I now speaking about something frequent, or is it something that is not that frequent and we don't really need to take care about it? And I'm showing you data from the US because they have done this work pretty nicely. This is the only work I know of which is really done pretty well in the general population, and they took the NHANES database. This is the National Registry or one of those. in the year 2009 and 2010. And they took also the different criteria sets. This is the one criterion set, the other criterion set, and also other criteria sets. And what they found out was that independent of which criteria set they used, the prevalence of inflammatory back pain in the general population was between 5 and 6%, which is, to my opinion, very frequent and very high. So you see here these numbers, 5, 5.6, 5.8, 6%, pretty high numbers of patients fulfilling the inflammatory back pain criteria. And this was, by the way, independent of the age group. So it didn't say that patients who are younger have more frequently inflammatory back pain and are candidates for spondyloarthritis, or those patients who are older. This means that also patients who are older need to be taken seriously into account for spondyloarthritis. And the other thing that I find even more interesting is that there was absolutely no difference between males and females. If you see here, the numbers are pretty similar. This means that obviously we might be underestimating females so far, saying that they might have other diseases. You can call it fibromyalgia or whatever. Anyway, we need to take care of these patients as well, independent of the age and independent of the gender. So if we now have agreed from what I showed you that we can identify these patients properly by having the correct referral strategies and by knowing that this is a frequent phenomenon, we would also like to know how to treat the patients. And so I'm going to show you in the next couple of slides what is the up-to-date treatment, let's say, recommendation for spondyloarthritis. Again, this is something I showed you before, the slide with NSAIDs at first and TNF blockers at second, especially with patients with axial disease. This is the last update we had in the year 2011. We are now working on the update of these recommendations, which I hope will come out at the end of next year and will include, for sure, more possibilities for treatment with biologics than TNF blockers. So, if we want to treat, we all know this treat to target algorithm that says that we need to get the best target out of every patient and so on. I think that's something trivial and straightforward. We really need to aim for remission or to aim for low disease activity. So if you're working in rheumatology, especially if you're dealing with spondyloarthritis, you might know that remission is extremely difficult to reach, simply because the definition of remission includes function, which is very good. So the function needs to be very good. But obviously patients with spondyloarthritis, especially with later stage of the disease, will never be very good in function because they have advanced disease. So our aim here is mainly this one, the lowest possible. The recommendations for treating patients with spondyloarthritis also say, and that's relevant also for gastroenterologists, that you have to try at least 2 NSAIDs over at least 4 weeks. I mentioned before, high dose NSAIDs, so the maximum dose, 4 weeks. And if this does not work, this means there is still high disease activity. We measure it with an index called MAST line. It goes from 0 to 10. If it's more than 4, it's high disease activity. Plus, of course, when the physician, the expert, needs to be convinced that this is high disease activity to the disease. Anyway, then you would give a TNF blocker. So at least 2 NSAIDs. And maybe also sulfasalazine. Now, what is the evidence for using NSAIDs? How well and how fast do they work? Is this enough, or is it maybe too short? And what about sulfasalazine? Should we be giving it concomitantly or not, especially on the background of a silent inflammatory bowel disease? So, is there a benefit by using sulfasalazine? This is something that was published this year, and obviously what they found was what we knew. They found that, and this is the adjusted p-value for the changes or improvements in response, what they found was that there was only one reason to use sulfasalazine, and this was in order to improve the MAST score, this means the disease activity score, and especially
the peripheral pain score. You see here, these are the only p values that really matter. This is something we know, since as far as it doesn't really help. So what about other PMAs, especially methotrexate? What I'm using here are the data taken from the Swedish registry that show not only efficacy but also drug survival. This means how long will the patients stay on biologics by having a communication of especially methotrexate, and as you can over 5 years, and as you can see here, there was a positive effect, especially with patients with ankylosing spondylitis, not so much with undifferentiated disease. So patients who took methotrexate or who took DMARDs stayed longer than TNF blocker, as compared to those who did not take DMARDs. Sorry, here, those who took DMARDs as compared to those who did not take DMARDs. What does this mean? This means that obviously we can improve the duration of treatment with the TNF blocker by giving a methotrexate or other DMARDs, but clinical efficacy, we know it from other data, will not improve. I cannot explain to you why this data come like this. This means why do I have a positive effect in drug survival without having clinical efficacy? Maybe it has to do with information of anti-drug antibodies. It could be. But we don't really know it. This is an analysis of the registry without really having blood tests done. Now, the next, to me, very important question is what about NSAIDs? I call it efficiency and not efficacy because these data are taken from a daily practice. And what we have tried to do here was to take 100 patients with spondyloarthritis and give them full dose NSAIDs over 4 weeks continuously, which is what the recommendations say. And try to find out how fast and how well the NSAIDs would work. Here you see the non-radiographic and the radiographic spondyloarthritis. You see there were no differences, and what this slide tells us very nicely is that if you have patients with high disease activity and you give them NSAIDs over 1 week, full dose, then there will be decreased, and this will be significant decrease of disease activity already after 1 week, which is, I believe, an excellent result. But if you wait and to see whether this works even better, this will not be the case. This means what we can achieve with NSAIDs can be achieved within 1 week. There is no need to wait longer for even better efficacy. If NSAIDs do not work after 1 week, we need to change them. There is no efficiency, there is no, benefit of the patients taking NSAIDs for longer than 1 week. If they don't respond, you have to change it. Now, going into the treatment with biologics and what we do know about biologic treatment here, in spondyloarthritis, we do know that after 6 months we have many patients who respond well to biologics, and there is obviously also no difference between the compounds, so obviously we do have, at least with the TNF blockers, a very good effect. The question that I believe is even more interesting is how long should we treat these patients? And is there a way to modify this treatment? What I'm showing you here are data from the Czech registry. And the pretty interesting question that they tried to answer here was whether, if a patient or when a patient is responding to a TNF blocker, whether they can modify, this means reduce the dose or not. These are the different parameters that they used: BASDI, CRP, HAC, function, and so on. And these are the results of the patients who stayed in the same dose. This means they were in a good shape, they have responded well, and they continued taking the TNF blocker, as compared to those patients who reduced the TNF blocker. So you have a patient who is doing well about 1 year on the TNF blocker. Do you continue or do you reduce? So what they found was that if they would reduce the dose and they would compare the data to those who were taking the dose of the TNF blocker the same way, there would be no difference in disease activity outcomes. There would be no difference in HAC. There would be no difference in function. So obviously, in a patient who is doing well, we are able, without losing efficacy, to reduce the dose. Patients will actually still continue doing well. treatment with TNF blockers would be also whether we can not only reduce the dose, but also whether we can predict efficacy. What we've done here was to say, or to ask the patients who were 8 years long on a TNF blocker, or to analyze them, and analyze the probability of being, after 8 years, either on remission, or in a very good shape, or maybe having stopped the drug. And we try to find out which are the predictors of the good response after 8 years. What came out pretty nicely was that the best predictor for a long-term response with the TNF blocker is the rapidity, the velocity of response within 3 months. What do I mean by that? We assume and we know that all the patients who were treated, at least in this study, had a BASTI of more than 4. This means 4, 5, 6, and 8, 9, 10. The better the response after 3 months, this means the BASTI dropped down to 3, to 2, or to 1. The better the response also after 8 years. You see that patients who dropped down their BASTI from more than 4 down to 1, they have much higher probability of more than 60% of being good responders after 8 years, as compared to those patients who were having a drop down of the BASTI from more than 4 to 3. Their probability to be in BASTI 50 was about 23%. And the other way around, the probability to be a dropout, this means having stopped the treatment within 8 years because of inefficacy, was higher in those patients. So obviously, good response can be predicted when we have a fast response in the very beginning. And now, if you remind yourself, who are these patients who are going to show the good response? These are the patients who are young, I told you in the first talk, who are having high CRP, and also might be positive for ileonoscopy, especially for acute inflammatory lesions. The other thing that I found pretty interesting that was published within the last 2 years was this study that was published by Maxime Bellos in France, taking the patients who were on anti-TNF and those who were actually taking NSAIDs or not anti-TNF, and what they found out was that obviously after 2 months there is a decrease of an NSAID treatment if you're giving a TNF blocker. This is pretty straightforward and pretty obvious. Nevertheless, it shows very nicely in numbers that a TNF blocker treatment will help us reducing NSAID treatment, which might of course be associated with less comorbidities in the long term. Now, what is the very new stuff? So what other biologics, what other molecules might be useful for treatment of spondyloarthritis? We do have different targets, we do have different compounds, and we see here the efficacy so far in spondyloarthritis. And unfortunately, we will not have all these drugs being approved in spondyloarthritis. I mentioned that before. IL-17 inhibition, especially with sepikinumab, will be approved in at least in Germany in the next couple of weeks. There is also the IL-12/23 treatment with sepikinumab that is ongoing. The trial is ongoing right now. JAK kinase, the trials on the whole program was stopped 2 weeks ago, unfortunately, because it didn't find so good response there. And all the other trials have not shown any efficacy in patients with spondyloarthritis. And what I'm showing here are just the preliminary data of all these compounds that have shown a good response, especially IL-17 treatment. You see here in 150 milligram dose, this will be the approved dose of sepikinumab worldwide for spondyloarthritis. There is a very good response, which is exactly the same as what we know from TNF blockers. There has been a proof of concept study, an open label study with IL-12, IL-23 inhibition, and here you see similar results for IL-20, IL-40. Again, maybe higher numbers because of the open label study, but anyway, data are also very promising. I think this drug will also come into the market pretty soon. This is something pretty interesting, and this has to do with a small molecule. The only one that has been published so far it's actually still ongoing in spondyloarthritis, this apremilast, the phosphodiesterase 4 inhibition. And what we found was that actually treating patients with apremilast, this would lead to a good response. This is the response on the decreasing mast type. However, that's the interesting thing for us physicians, is that this drug was not followed up in spondyloarthritis. We don't know why, but nevertheless the drug at least it seems that will not come out in the market of this disease, although if, as you can see here, when the patients stop the drug, they worsen again. We do now are examining the 2-year data of the same program, still knowing that the drug will not come to the market. This is something we, or one or the other, might interpret differently in terms of the politics, but anyway, it is not something we will see very soon in spondyloarthritis. We now know also that there will be new indications, or let's say new targets of patients that will be treated with biologics. Here you see the ability-2 trial. This means a trial with the TNF blocker in peripheral spondyloarthritis. And as you can see here, with this new index, we don't need to discuss what exactly this evaluates. Nevertheless, we have seen a significant response also in the peripheral spondyloarthritis patients. This means that we are now able to treat the entire spectrum of spondyloarthritis, both the axial and the peripheral symptoms. Now, what else is new in the spondyloarthritis field in the year 2015? I would just like to mention 1 or 2 things about imaging and 1 or 2 things about genetics. First of all, when we talk about imaging, I would just like to remind you that we talk about a positive MRI, especially in the sacroiliac joints, that shows inflammatory activity in many lesions, and also, of course, about the positive X-ray in this case. However, we also need to know that there are new data speaking about radiographic progression in these patients, and this is a hot topic simply because we know that the patient will ask about radiographic progression and whether TNF blockade will inhibit radiographic progression in AS. After 2 years, there has been no improvement by this or by using these 3D studies in terms of radiographic progression as compared to NSAIDs only. I take this example here with Paracet, for example, the radiographic progression was going up, and the same was true for NSAID treatment in this cohort. This means there was no difference. And at least according to this data, it was a little bit disappointing to see that the TNF blockade did not stop radiographic progression in AS. What we have done was to take care of the patients with spondyloarthritis or ankylosing spondylitis over longer periods of time. This means more than 8 or 2 years. And we found out that if we would compare patients with NSAIDs and patients with anti-TNF, indeed, we could not see, even in our cohort, a difference between those 2 groups. This is the line going up for the progression, for the worsening. However, we could see some differences, and this was also statistically significant after the 6th and after the 8th year, which means simply that as an update of radiographic progression and long-term treatment with TNF blockers, we believe that we will be able to influence radiographic progression, but we need to treat patients long times. This means more than 6 or 8 years. And this was what I showed you before, was the results of the score. Here I show you the same cohort with respect to the number of desmophytes per patient. This is baseline, this is NSAIDs, this is anti-TNF, and this is what happens after 8 years. You see statistically significant and huge difference between the new desmophytes that were developed in this group and the only one per patient developed in this group. So obviously there is a benefit by taking the TNF blockers, but we need to treat patients very long. Who is the one who is going to stay on that treatment? The patient who is showing a good response. I mentioned that before. A good response early enough. And the other thing that the Canadian showed very nicely was that there is also a benefit by starting early with the TNF blocker. This means if a patient starts within the first 5 years of diagnosis, he will have less radiographic progression as compared to those patients who start, for example, after 10 years. They have much more radiographic progression. So obviously, there is a reason to believe that early treatment will lead to a good response, The patient will maintain their treatment over 8 years, and also they will benefit by having less syndesmophytes. The other thing that we also need to take into account is that if we leave patients untreated, this means those who are having a high disease activity, their radiographic progression is much higher as compared to those who are having low disease activity. So we really need to take care about the treatment all the way along. The better the treatment effect, the longer patients will stay on guard, and the longer they stay on the guard, they don't just benefit clinically, but also radiographically. What is the very new in the treatment? What is the very good news or the news in the imaging of these patients? It is that we all have more sophisticated imaging techniques nowadays. For example, PET techniques as compared or combined with MRI. You see here the pretty nice images we were able to produce for both the spine but also the sacroiliac joints, simply saying that we are not, or we will not only be able to evaluate and image inflammation or maybe chronic changes, but by using the appropriate techniques, we will also be able to visualize those sites that are not only inflamed but also showing the osteoblastic activity. This is a tracer, this is a compound that really focuses on osteoblasts only, and you see here how nicely we can show, even in non-inflamed areas, where there will be new bone formations. That means we can really predict the course of the patients by using new imaging techniques. And the last thing I would like to mention is the genetic background and the news about whether we are able or not to identify patients by their genetics. And mentioned that many times already. We know that there is a different distribution in the HIV-27 prevalence. This might not be entirely true anymore. This is an older slide from 1995. Nevertheless, we do know that there are differences in the southern and northern part of the world with respect to the prevalence of HIV-27. We have been working pretty intensively in Germany to find out new genes that might be associated with spondyloarthritis. And one thing that we found was that if you have a patient who might be tested for different stuff, for example, for antibodies against the CD74 molecules, and especially the IgG antibodies against it, there are certain peptides on the cell surface, especially the macrophages, that might be associated with this test being positive. Then you will find many patients with spondyloarthritis, either older but also younger patients, who are positive for this test, despite all the other autoimmune inflammatory diseases. And what we have been able to publish last year was that actually there is, and I go faster through this, there is also a very high sensitivity and specificity with a very high negative predictive value of this test as compared to HIV-27. Simply saying that obviously this part of the criteria might be able, I would say in 1 or 2 years, but maybe in 5 or 10 years from now, to be modified as a genetic background are independent on which part of the world we're at, and maybe also helping us diagnose patients earlier in order to get also the better treatment earlier. Thank you very much for this. Thank you very much for the attention, and more any questions.
Thank you.